Study Session 11. Somatosensation. Introduction. In this study session, we'll examine one of the means by which human beings respond to changes in the environment, the sense of touch. If you slightly press one of your fingers to a hot teacup, you will feel pressure and warmth. If you touch a hot iron, you will feel pain. If you press your hand against an ice cube, you will feel cold. What you have discovered is that the sense of touch is a mixture of a number of different skin senses, namely warmth, cold, pain, and pressure. On many other occasions, perception of pain is in response to pathological or psychological assaults going on in the body. Learning outcomes. At the end of this study session, you should be able to 1. Present the senses of touch. 2. Outline the mechanism for perceiving touch. 3. Highlight types of pain. 4. Describe the physiology of pain perception. Somatosensation. The sense of touch is not really one sense, but a combination of at least 4 senses, namely touch, pain, warm, and cold. There are 4 respective surfaces on the skin through which these senses could be perceived. These physiological processes are embedded in what is known as somatosensation. Somatosensation refers to a combination of processes related to perception of sensation as well as movements of the body. Mammalian skin has series of sensory receptors located peripherally in various parts of the body, with the ability to respond to a variety of sensory stimulus. The sensory receptors, which are unevenly distributed, could be explored with devices such as fine hairs, needle points, warmed or cold pointed hammers. Similarly, the separate sensing spots differ in frequency and location or anatomical distribution. A touch receptor may consist of a simple bird ending, an elaborated neuron ending, or a bare ending surrounded by non-neural cells that modify its functions. Kalat, 1988. Areas with greater sensitivity of the skin, such as the fingertips, have as many as 700 touch cells in 2 square millimeters surface. Different receptors are associated with different types of sensation. On receiving a stimulus, each of the information received takes specific pathways to communicate to specific areas in the brain. With this unique distinction, any localized tissue damage of a skin surface, for instance, could destroy the local tissue without destroying the perception of stimulus related to the area damaged or vice versa. On the other hand, because pain and temperature sensations are perceived along the same path, any injury that affects one path will automatically hinder the other path. Calet, 1988. Any information that passes through different paths in the spinal cord also reaches different parts of the thalamus and cerebral cortex. For example, a specific area of the thalamus responds to the activity of the Pacinian corpuscles, which responds to the stimulus of touch on the skin. Within the area, different parts respond to different receptors or combination of receptors. Dykes, Soar, Messenich, Cass and Nelson, 1981. Somatosensory areas and their functions. The various areas of somatosensory thalamus, sends their impulses to different areas of the somatosensory cortex, located in the parietal lobe. The somatosensory cortex includes 4 major parallel strips, each of which has its own representation of the entire body. Cass, 1983, identified these areas to include the following. 1. Hair follicle receptors, located in hair-covered skin, rapidly respond to movement of hairs. 2. Meissner's corpuscles, located in hairless areas of sudden displacement of skin, respond to low-frequency vibration. 3. Pacinian corpuscles, located in both hairy and hairless skin, respond slowly to indentation of skin. And 4. Ruffini endings, located in both hairy and hairless skin, respond slowly to stretch of skin. These areas of somatosensation remain at least partly separate from one another at all levels, from the receptors to the somatosensory areas of the cerebral cortex. Pain sensation. Pain is an unpleasant sensation occurring in varying degrees of severity. Pain is an unpleasant sensation occurring in varying degrees of severity as a consequence of injury, disease, or emotional disorder. Pain is an unpleasant yet important function for survival, similar to a warning system. In brackets, not all pain is needed for survival. It is a useful human experience that is best described by the sufferer. Pain is a sensation with strong emotional properties. It could be of various types: mechanically induced, chemically induced, intense heat, and intense cold. Lamotte and Collins, 1982. Description of the intensity of pain. Pain may range in intensity from slight through severe to agonizing. It is experienced as having qualities such as sharp, throbbing, dull, nauseating, burning, and shooting. It often has both an emotional quality and a sense bodily location. Medical professionals will sometimes ask patients to rate their pain on a scale of 0 through 10, where 10 is consistent with screaming and thrashing about. Description of the intensity of localization. This subjective reality of the localization of pain to an area of the body is the basis for speaking of pain receptor, neck pain, referred pain, cutaneous pain, as well as pain in my foot, kidney pain, or the painful uterine contractions occurring during childbirth. This common usage of pain is not entirely consistent with the scientist's model of pain being a subjective experience. Types of pain. Pain can be classified as acute or chronic. The distinction between acute and chronic pain is based on the nature of the pain itself and not on its duration of sensation. Acute pain. Physicians are more comfortable treating acute pain, which has as its source in soft tissue damage, infection, and/or inflammation. Such pains can be modulated and removed by treating its cause and through combined strategies using analgesics to treat the pain and antibiotics to treat the infection. It is not the pain itself that is short in duration. It is the diagnosis of acute pain and the expectation that it will be short in nature that continues to confuse both the medical establishment and those who experience pain. The primary distinction is this: acute pain serves to protect one after an injury. Chronic pain does not serve this or any other purpose. Acute pain is a symptom of pain. Chronic pain. Chronic pain was originally defined as pain that has lasted 6 months or longer. It is now defined as a disease of pain. Its origin, duration, intensity, and specific symptoms vary. The one consistent fact of chronic pain is that as a disease, it cannot be understood in the same terms as acute pain, and the failure to make this distinction, particularly in those who suffer chronic pain, has been and continues to be the cause of the multidimensional suffering, depression, social isolation, and helplessness. The failure to recognize chronic pain as substantially different from acute pain cannot be blamed on the medical profession. It is a societal lapse. Causes of chronic pain. The most common causes of chronic pain include 1. Low back pain, 2. Headache, 3. Recurrent facial pain, 4. Cancer pain, 5. Arthritic pain, 6. Psychosomatic or psychogenic cause. Chronic pain, no matter how debilitating it is in one's life, continues to be considered by most insurance carriers as a 3 to 17% disability. American Pain Association estimates that 40 to 80 million Americans live with chronic pain. At the same time, there are only 8,000 qualified pain management specialists. Chronic pain has no time limit, often has no apparent cause, and serves no apparent biological purpose. Chronic pain can trigger multiple psychological problems that confound both patients and healthcare provider, leading to feelings of helplessness and hopelessness. Types of physiological pain. These can be grouped according to the source and related nociceptors. Cutaneous pain. This type of pain is caused by injury to the skin or superficial tissues. Cutaneous nociceptors determine just below the skin and, due to the high concentration of nerve endings, produce a well-defined, localized pain of short duration. Examples of injuries that produce cutaneous pain include minor cuts, minor (first-degree) burns, and lacerations. Somatic pain. Such pains originate from ligaments, tendons, bones, blood vessels, and even nerves themselves. It is detected with somatic nociceptors. The scarcity of pain receptors in these areas produce a dull, poorly localized pain of longer duration than cutaneous pain. Examples include sprains and broken bones. Myofascial pain is usually caused by trigger points in muscles, tendons, and fascia, and may be local or referred. Visceral pain. This pain originates from body's viscera or organs. Visceral nociceptors are located within body organs and internal cavities. Nociceptors in these areas are more scarce and also produce pain that is usually more aching and of a longer duration than somatic pain. Visceral pain is extremely difficult to localize, and several injuries to visceral tissue exhibit referred pain, where the sensation is localized to an area completely unrelated to the site of injury. Myocardial ischemia (the loss of blood flow to a part of the heart muscle tissue) is possibly the best known example of referred pain. The sensation can occur in the upper chest as a restricted feeling or as an ache in the left shoulder, arm, or even hand. The brain freeze is another example of referred pain, in which the vagus nerve is cooled by cold inside the throat. Referred pain can be explained by the findings that pain receptors in the viscera also excite spinal cord neurons that are excited by cutaneous tissue. Since the brain normally associates firing of these spinal cord neurons with stimulation of somatic tissues in skin and muscle, pain signals arising from the viscera are interpreted by the brain as originating from the skin. The theory that visceral and somatic pain receptors converge and form synapses on the same spinal cord pain transmitting neurons is called Roch's hypothesis. Phantom limb pain. This is a type of referred pain. It is the sensation of pain from a limb that has been lost or from which a person no longer receives physical signals. It is an experience almost universally reported by amputees and quadriplegics. Neuropathic pain. This type of pain can occur as a result of injury or disease to the nerve tissue itself. This can disrupt the ability of the sensory nerves to transmit correct information to the thalamus, and hence the brain interprets painful stimuli even though there is no obvious or known physiologic cause for the pain. Neuropathic pain is the disease of pain. It is not the sole definition for chronic pain, but does not meet its criteria. Consequences of nociception. When the nociceptors are stimulated, they transmit signals through sensory neurons in the spinal cord. These neurons release glutamate, a major excitatory neurotransmitter that relays signals from one neuron to another. If the signals are sent to the reticular formation of the brainstem and thalamus, then pain enters consciousness, but in a dull, poorly localized manner. From the thalamus, the signal can travel to the somatosensory cortex in the cerebrum, when the pain is experienced as localized and having more specific qualities. Feinstein and colleagues found that nociception could also activate generalized autonomic responses independently of the relay of pain to conscious levels, causing pallor sweating, bradycardia, a drop in blood pressure, subjective faintness, nausea, and syncope. Feinstein, Langton, and Schiller, 1954. Study session summary. From the foregoing, the sense of touch consists of 4 senses, namely touch, pain, warmth, and cold. Somatosensation is a physiological process by which the skin perceives sensation as movement of the body. The various areas of somatosensory thalamus send their impulses to different areas of the somatosensory cortex located in the parietal lobe. End of study session 11. Thank you for listening.